morning, everyone. I'm the Associate Professor Chiu. I'll be moderating the first talk today. So today we are privileged to have Dr. Saturveithan to give you the first breakfast talk. He is a graduate of University of Malaya, and also he obtained his Master's of Orthopedic Surgery from University of Malaya. He is the top student of Masters of Orthopedic Surgery 2020, and he's currently has joined the orthopedic department in the spine subunit as a lecturer. Besides being a top student in the Masters, he also have won many awards in his research and publication and in the regional and international conferences. He'll be presenting to you a topic that is commonly encountered, osteoporotic fractures among our elderly population. So without any delay, I will pass over to Dr. Sato to give you the talk.
So I'm Dr. Saturveithan from Department of Orthopedic Surgery. My topic of presentation will be surgical management of osteoporotic vertebral compression fractures. There's no financial conflict of interest to disclose in relation to this presentation. This will be the outline of my presentation. Fractures in osteoporotic patients are one of the most challenging issues, and the optimal treatment remains an unresolved patient. This is a 70-year-old lady presented with T12 fracture in 2011. Subsequently, the next year, she suffered from T9 fracture, and the following year, she had a T7 and T11 fracture, which contribute to a progressive kyphotic deformity. Chronic pain and kyphotic deformity may lead to depression, decreased pulmonary function, impaired mobility, and reduction in the quality of life. So how we diagnose osteoporotic vertebral fractures? So acute fracture can be diagnosed based on an X-ray or CT scan showing a sharp cortical pairing with the existing old radiograph or an MRI scan. This slide shows the MRI scan whereby we can see an acute fracture. In T2 weighted image, there will be reduced in signal. In comparison with T2 stir weighted image, there will be increase in signal showing bone edema, which indicates acute fracture. This is an example of another patient. In T2 weighted image, we can see a fracture at T11, T12, L2, and L3 region. An MRI stir fat suppression sequence shows T11 and L2 was an old fracture, as there's no increase in intake, and T12 and L3 is the new fractures. Majority of these fractures will heal spontaneously. It's a self-limiting cause. If painful, usually it subsides gradually over a period of 6 to 12 weeks with conservative management. However, some patients will develop intravertebral cleft or cavity formation, which means it's filled up with fluid, or intravertebral pseudoarthrosis filled with air. Failure of the fracture to heal naturally results in constant movement, which will lead to cleft formation and pseudoarthrosis at the fracture site. How we diagnose intravertebral cleft? MRI scan shows an intravertebral cleft filled with fluid. It's known as fluid sign, whereby we can see in T2 weighted image, there's increase in signal, indicates fluid sign. X-ray or CT scan showing intravertebral cleft filled with air indicates the intravertebral vacuum cleft phenomenon. A vacuum sign can be seen in the X-rays as pointed by green arrows, or can be assessed based on CT scans. Dynamic mobility has been described by McKinnon and Chen. A sitting radiograph will be obtained, which shows the fracture has collapsed. Subsequently, a supine stress radiograph using a bolster will show the fracture site open up. So this shows a dynamic mobility whereby the fracture site which has collapsed is opened up by stress films. This shows another example whereby we can see the compressed fracture which has opened up in dynamic stress films. This brings to our management of our topic, osteoporotic vertebral fractures. So the management can be divided into non-surgical and surgical. Non-surgical includes bed rest, pain management, bracing, back care, physical therapy, psychosocial support, and osteoporosis management. We routinely refer to our RUCA colleagues for continuation of the osteoporosis management because this plays an important role in the non-surgical management of osteoporotic patients. Surgical options can be divided into patients with fracture and patients with fracture with neurology. Options of treatment for patients with fracture will be percutaneous vertebroplasty, kyphoplasty, minimal invasive stabilization for patients with large intravertebral cleft. Patients with neurology, options will be surgical decompression and instrumentation or minimal invasive stabilization. Percutaneous vertebroplasty reported to have significant pain relief in many studies. Vertebroplasty has been reported to relieve pain better and improve quality of life as compared to conservative management. So the indications for percutaneous cement vertebroplasty will be symptomatic acute fracture which has failed conservative management or symptomatic fracture with dynamic mobility. Symptomatic means patients present with instability back pain, severe excruciating pain, especially over the paravertebral region, aggravated by changing position, getting up from lying down and turning on the bed. Here we show the surgical technique of PCV. Routinely is done under local anesthesia and sedation. So once the trocar inserted into the vertebral body, saline flushing will be done to clear the debris at the cleft region and to ensure there's a smooth flow in and out between the two trocars. Subsequently, cement will be filled in the cleft gradually and monitored using a fluoroscopic guidance. Cement retrograde flow at the opposite trocar indicates the cement has filled the cleft. This is a fluoroscopic image of a vertebroplasty, AP and lateral views. Cement distribution can be divided into two patterns, trabecular pattern or cleft pattern. Trabecular pattern is usually will be in acute fractures, and cleft pattern can be observed when we inject cement into an intravertebral cleft. Kyphoplasty, in the other hand, is another technique which is also known as balloon-assisted vertebroplasty. A balloon will be inserted first, and the cement will be injected inside the balloon to complete this procedure. Vertebroplasty versus kyphoplasty both provided significant improvement in VAS pain scores as well as functional recovery. Cement leakage has been noted to be higher in the vertebroplasty. However, most of the cement leakage was clinically asymptomatic. No evidence that vertebroplasty and kyphoplasty increases the risk of adjacent vertebral body fracture compared to the non-surgical treatment group patients. Patients who presented with fracture with neurology, whereby they have significant neurological deficit that does not improve with bed rest, open decompression should be considered. open decompression to decompress the spinal cord, and instrumentation to stabilize the spine. This is a case example, 89-year-old lady with T12 fracture intravertebral cleft, as shown in the CT scan. Patient presented with neurological deficit, however, it improves with bed rest. And we proceeded to do a percutaneous cement vertebroplasty for T9 and minimal spinal instabilization for T9 to L2. So there's a new technology whereby percutaneous pedicle screw stabilization system, a minimal invasive technique to insert the pedicle screws. The advantage of this technique will be less soft tissue trauma, less skin incision, less blood loss, early rehabilitation, shorter hospital stay, less pain, and it preserves the muscular attachment for better function. Hereby, we show the surgical technique of MIST. The trocar will be inserted into the pedicle and once into the body. Subsequent guide wire will be inserted and screws will be inserted each level. A rod will be subsequently inserted via a keyhole incision. And with these 8 small incisions, we're able to insert all the 8 screws and 2 rods and perform PCV. This is a case example whereby patient had T11 fracture with cleft compressing on the spinal cord. Indirect decompression was achieved using MIST technique and percutaneous cement vertebroplasty. Regarding short versus long segment fixation, fixation can be 1 level above or lower, or can be high more than 1 level. Factors that influence the decision-making will be need of sagittal alignment correction, presence of anterior column support, and the rigidity of the spinal column above and below the fracture site. Enclosed spine, in cases of dish ankylosing spondylitis, usually require a long segment fixation. This shows a CT scan of a patient with T12 OVCF, osteoporotic vertebral compression fracture with intravertebral cleft, and patient had enclosed spine above the fracture level. So we did a long segment fixation and percutaneous cement vertebroplasty for this patient, and union was achieved in 9 months duration. This is another example of 70-year-old gentleman with ankylosing spondylitis, sustained T11 fracture with large intravertebral cleft. Union was achieved in 1 year after a long segment MIST fixation. We have published a paper comparing minimal invasive versus conventional open surgery for fixation of spinal fractures in enclosed spine patients. And we have shown that operative time is significantly lower in MIST group, and the blood loss is significantly lower in MIST group compared to traditional open techniques. In conclusion, there are different types of OVCF: acute fracture, or fractures with intravertebral cleft or pseudoarthrosis, which is filled with fluid or air. Conservative management is a standard treatment for acute OVCFs. The incidence of OVCF with dynamic mobility is higher than expected, and this group of patients will benefit from cement augmentation. OVCF with intravertebral cleft can be diagnosed easily on radiographs, CT scan, and MRI scans. Minimal invasive surgical options available to treat this condition, providing a good functional outcome. Thank you.
Thank you, Dr. Sato. Let me check whether there's any question from the audience. So if there's no question, maybe I can start off with a question. Just to ask you, since osteoporotic fractures can present in the outpatient clinic, in the general RUCA or other clinics, so how would you suspect that a patient have an osteoporotic?
Generally, patients with osteoporotic fracture will have difficulty in walking because of the severe pain, and they'll have pain especially at the paravertebral region. We can differentiate with instability back pain, whereby patient will have pain upon movement, especially when they are getting up from a lying position or turning in the bed. When patients have pain upon motion of moving, turning side to side, or getting up from bed to sitting position or sitting to standing position, that indicates instability back pain. And usually patient will be coming on a wheelchair, or family members will have to help them to get on the wheelchair to see the doctors.
Thank you for the answer. Prof. YK Chan asks, how long does the cement take to solidify from the liquid state?
We usually use high viscosity cement, medium to high viscosity cement, which solidifies within 5 to 7 minutes. So the moment we inject the cement, we'll be looking for the retrograde flow from the opposite trocar. The moment the opposite trocar has retrograde flow, that indicates the cleft has been filled up. And when we cannot inject further cement because the cement has solidified, that indicates our procedure need to be stopped. And usually we inject by monitoring under fluoroscopic guidance.
Yeah, just to add more specifically the timing, I think the cement, it depends on what type of cement you use, but I think the solidification of the cement will take within 5 to 10 minutes, and the full hardening will take slightly longer, maybe half an hour, 1 hour. But usually we ask the patient not to move for half a day to a day, just to be sure. Yeah, Prof. YK Chan also asked, do you need to wait for cement to solidify before closing the surgical site?
No, routinely we do not wait for the cement to solidify. The moment we have retrograde flow that indicates the cleft has been filled up, then we will stop the procedure and we can close up the wound. And as Prof. Chiu has mentioned, usually we will advise the patients to lie on their back for at least half a day to 1 day post-operatively.
Yeah. So
before
Prof. YK Chan,
mobilization.
okay. Prof. YK Chan also asked, does it cause anaphylaxis the way cement for hip surgery sometimes does?
We inject the cement in acute fracture. We need to be very careful to monitor the injection of cement, as it will be an trabeculate pattern. So we need to monitor whether it spreads rapidly or in a slow progressive manner. If it's rapidly spreading, that means you are injecting into a vessel at the fracture site, which can be dangerous and can lead to cement implantation syndrome.
Yeah, so to summarize, I think in short, the answer is yes, it can. But I think compared to hip surgery, hip surgery sometimes use pressurized cement, so that will increase the risk more than the spine cement injection, unless you use a pressurized system to inject the cement. Yeah. So like what Dr. Sato showed is we use 2 trocars to reduce the pressure of injection of cement. The opposite trocar will allow some cement to retrogradely flow out when the pressure is high. Prof. YK Chan asked again, same type of cement for both. There are a few types of cement, but we usually use the basic type. It depends on surgeon, but in general, the answer is yes. The cement is the same for both hip surgery or knee surgery or spine surgery. Any more questions? Maybe Dr. Sato, is there, can I ask you to explain which patient needs surgery and which patient can be treated conservatively?
In general, patients with acute OVCFs can be treated with conservative management by bracing and management. The indication for surgery will be patients who have symptomatic fracture, which has failed conservative management for a period of, usually we brace the patient for 4 to 6 weeks. And if the patient still presents symptomatically by complaining of instability back pain, after the 4 to 6 weeks, we can offer surgical treatment, which is a percutaneous cement vertebroplasty. Besides that, we also look for dynamic mobility. And when patient presented with symptomatic fracture with dynamic mobility indicating of cleft, then patients indicated for surgical intervention, as I explained in my slides. So the options will be either a percutaneous cement vertebroplasty plus minus a minimal invasive stabilization.
Is there any group of patients that you need to watch out that has high risk of developing neurological deficit with osteoporotic fracture? And this patient may be we may need close observation or more to a more early surgical intervention. Is there such a type of patients?
Yeah, patients with fused spine, including spondylitis, they have higher risk to develop neurological deficit, and usually conservative management in this group of patients will not be successful, and they require a long segment fixation to stabilize the spine.
Yeah, Prof. YK Chan has another question. She says that I have a family history of osteoporosis and my mother has spinal fractures, just as described. So I'm maybe a likely candidate needing care in the future. So how to prevent myself from being one besides taking all the measures to strengthen bone, reducing stress on spine?
Oh, okay. So prevention of fracture, how to prevent myself from getting all the measures to strengthen the bone, reduce the stress on spine. Reduction of stress on the spine can be made by following a strict postural training, and do not carry heavy objects when you are diagnosed to have osteoporosis, and reduce activities that can lead to a fracture, especially heavy activities such as hiking. Besides that, we'll usually advise our patients to strengthen their back muscles by doing a strengthening exercise over the spine. And we routinely give our pamphlets to our patients for the postural training as well as strengthening of the back muscles. In regards of the osteoporotic medical management, we routinely refer to our RUCA colleagues as they are more expert in that field compared to us as spine surgeons.
Okay. I think thank you very much, Dr. Sato. There is another talk after this. So thank you for all the questions, especially from Prof. Chan. And I would like to pass over this session to the next moderator and to the next speaker. Thank you, Dr. Sato.
Thank you, Prof. Chiu, and thank you for the opportunity to present in this breakfast talk. Thank you.